My topic for today's discussion is intraoperative desaturation. Desaturation or hypoxemia is defined as a condition where the arterial oxygen tension is below normal, the normal saturation being 80 to 100 mm of Hg. Being said that hypoxemia is considered as the far most common cause of tissue hypoxia. Common causes of desaturation are classified into two categories. First is the problem with the oxygen delivery system, and second is the problem with the patient part. First, to deal with is the oxygen delivery system. This could be at the level of central oxygen supplies or at the level of a pipeline distributing system, at the level of oxygen cylinders attached to the anesthesia machine, at the level of anesthesia machine itself, at the level of the ventilator or the anesthesia circuit or the endotracheal tube. At the level of the central oxygen system, there can be a gas leak or a decreased oxygen level in the tank or the depleted cylinders. At the level of the pipeline distributing system, there can always be a leak, contamination of the gases, or connecting the wrong hose to the oxygen yoke. At the level of oxygen cylinders which are attached to the anesthesia machine, there can be empty cylinders or substitution of the non-oxygen cylinders with the yoke or insufficient gases in the cylinder. At the level of anesthesia machine, there can be incorrect setting of the flow meter, cracks in the flow meter, or leaks in the machine. At the level of the ventilator, there can be low tidal volume being delivered, low respiratory rate, inadequate minute ventilation, or there can be disconnection of the tubings. At the level of the circuit, there can be disconnection or leaks. At the level of the endotracheal tube, there can be esophageal intubation, endobronchial intubation, accidental extubation, kinking of the tube, or the obstruction of the ET tube by thick secretions. Next, coming to the patient problem, there can be first and foremost is the hypoventilation, because in spontaneously anesthetized patient, they can always hyperventilate due to drug-induced respiratory depression or maybe due to inadequate positive pressure ventilation. There can be second is the reduced FRC. Induction with general anesthesia will cause a reduction in FRC by 15 to 20%. So in patients, in obese patients or pre-existing lung disease patients, this becomes a contributing factor for desaturation. The reduction in FRC is continued in the post-operative period as well, and decreased FRC causes the increased arterial and the alveolar oxygen gradient. So the reduced FRC can be restored by application of PEEP. There can be increased airway resistance, which could be due to again reduction in FRCs, endotracheal intubation, laryngospasms, or obstruction of endotracheal tube. There can be atelectasis, which can be microatelectasis, macroatelectasis, or lobar collapse, which leads to the ventilation perfusion mismatch, the right to left shunting, and ultimately arterial hypoxemia. Atelectasis can also occur due to airway secretions, compression packs, the wedges or the bolsters used during surgeries and during prolonged procedures. So PEEP, in such cases, PEEP may be useful. There can be a diffusion defect, even though we are supplying adequate oxygen to the alveoli. Defect at the alveolar level reduces the absorption of oxygen into the blood, and this could be due to thickening of the alveolar membrane, which damages the air-blood interface. There can be inflammation, alveolar edema, or fibrosis of the alveolar surface, gas exchange surface, like in disease of sarcoidosis or emphysema. There can be acute shunt, which could be due to inadequate ventilation, like absorption atelectasis, airway secretions, aspirations, pulmonary aspirations, pulmonary edema, or inhibition of HPV, hypoxic pulmonary vasoconstriction. These could also be due to inadequate perfusion as well, like in AST, septal defects, AST, VST, patent foramen ovale, pulmonary embolism. Inhibition of hypoxic pulmonary ventilation, which is a protective phenomenon when arterial oxygenation decreases in a particular pulmonary region, vasoconstriction occurs at that region, and HPV directs the blood from the hypoxic region of the lung to a better ventilated region, thus decreases the VQ mismatch, maintaining the arterial oxygenation. So inhibition of HPV leads to arterial hypoxemia, which could be due to vasodilators like NTG or sodium nitroprusside, inhaled anesthetics, hypocapnia, hypothermia, or thromboembolism events. So there can also be desaturation in special conditions like laparoscopic surgeries, which is very common and may be due to pre-existing patient conditions like obesity, cardiopulmonary dysfunction, or hyperventilating patient due to ET tube obstruction, or intrapulmonary shunting due to decreased FRC, pneumothorax, emphysema, or endobronchial intubation, reduced cardiac output in cases of hemorrhage, impaired venous return, or myocardial depression or carbon dioxide embolism. There can also be desaturation in cases of pneumothorax, the causes being again decreased in FRC. Or blunt trauma to the chest, which can be treated by ICD insertion. In children, the neonates and infants are more prone to rapid desaturation because of the smaller caliber of the airways. Chest wall and airway are highly compliant. Increased oxygen consumption by this age group. Premature infants have the surfactant deficiency, which can always lead to hypoxemia. A difference in the airway anatomy can lead to difficult intubation, mask ventilation, and spontaneous extubation, early fatigue, and apnea due to lack of type 1 muscle fibers. In pregnancy, the FRC is also reduced by 20%, and hence the oxygen consumption is increased by 20%. So, in pregnant females are more prone for precipitous fall in arterial oxygenation, even for a brief period of apnea. And these patients are prone to difficult intubation and difficult ventilation and aspiration, tops of the risk for desaturation. Pre-oxygenation is must in this group of patients, and rapid sequence induction is preferred. In elderly, these patients are more prone to hemoglobin desaturation, because this group of patients have compromised cardiovascular system. So and also prolonged drug effect is seen, particularly the sedatives, narcotics, and the muscle relaxants can lead to hypoxemia in these patients. In obese patients, they have decreased lung volumes and hence the capacities. The expiratory reserve volume is the only oxygen reserve. These patients are prone to difficult mask ventilation, difficult laryngoscopy, and difficult intubation. Pre-oxygenation is less effective in such patients, and FRC is further reduced in supine position. And such patients are more sensitive to depressant effects of the hypnotics and opiates as well. During one lung ventilation, hypoxemia occurs in almost all cases during all cases of one lung ventilation. So this is due to ventilation perfusion mismatch, because the non-dependent lung is not ventilated but continuously gets perfused throughout the surgery. So measures to be taken in order to maintain the oxygenation during one lung ventilation is: two lung ventilation should be done as long as possible. High FiO2 must be maintained. If one lung ventilation is to be done, it should be started with a tidal volume of 10 ml per kg. We should adjust the respiratory rate so that the EtCO2 is maintained within a limit of 40 mm of Hg. Monitoring of oxygenation and ventilation should be done continuously. Non-dependent lung should be given CPAP, and the dependent lung should be on PEEP, and intermittent two-lung ventilation should be done, and pulmonary artery should be clamped as soon as possible. There can be diffusion hypoxia when at the end of the procedure, when the GA is over, the switching of the nitrous and the oxygen, and the patient, when the patient is allowed to breathe in the room air. So this contributes to diffusion hypoxia. There is this is more concerning during the first 5 to 10 minutes of recovery. Hence, administration of 100% of oxygen is essential to overcome this saturation. So, coming to diagnosis of desaturation, monitors in today's events, several monitors are used to detect hypoxemia. Pulse oximeter is the most commonly used monitors. Apart from this, oxygen analyzers, ABGs, capnographies, and airway pressure monitors can always be used. The standard ASA monitors, the standard one monitors are the qualified anesthesia provider, which can monitor the patient throughout the anesthetic procedure, and the standard two are the patients are the monitors which monitor the patient's oxygenation, ventilation, circulation, temperature, um, in a continuous manner. So assessment of oxygenation involves the measurement of two parts. So the measurement of inspired gas with an oxygen analyzer, and the assessment of hemoglobin saturation with a pulse oximeter, and the observation of skin color. Severe desaturation will ultimately cause a cyanosis, and cyanosis occurs only when the deoxygenated hemoglobin is more than 5 gram per 100 ml. So, at this, cyanosis is usually observed when the HB saturation is 85% or below, and this corresponds to PaO2 of 45 to 50 mm of Hg in adults and 35 to 40 mm of Hg in infants. Coming to troubleshooting plans and the management, first and foremost is to stop the ask the surgeon to stop the surgery. Second is to expose the chest and all the airway connections, giving 100% of FiO2, hand ventilating the patient, confirming that the FiO2 gets delivered to the patient, confirming the ET tube position by auscultation. If there is endobronchial intubation, we have to fix the tube properly, or any obstruction in the ET tube through secretions, we have to clear that. Checking the ventilator part. If there is any leak, we have to fix the leak in the ventilator. If the patient is having a decreased FRC, we have to hyperventilate with adequate PEEP. Absorption atelectasis, if suspected, then we have to decrease the FiO2, and if increased airway pressure is there, we have to deepen the plane of anesthesia. Salbutamol infusion, nebulization should be done, and aminophylline infusion can be started. If hypovolemia is there, adequate IV fluids and blood should be administered. Increased if there is situation which demand increased oxygen, then 100% oxygen should be maintained, and in cases of pneumothorax, ICD should be put. In cases of methemoglobinemia, in certain which certain drugs cause methemoglobinemia, 100% of oxygen should be given, and injection methylene blue 1 to 2 mg IV should be given. Prevention of such events can be prevented by anesthesia. Machine checkup should be carried out properly before every anesthetic procedure. Machine with proper oxygen pressure failure alarm should be used. Hypoxic guard in the anesthesia machine should be checked. Oxygenating providing devices should be present. Oxygen flow meter tube should be placed downstream, and checking the valve to prevent the gases from the machine the flow of gases from the machine to the cylinder or pipeline should be checked. That's it, sir.
Fantastic. Very nice, beautiful presentation. What does desaturation mean?
So desaturation is basically when the arterial saturation is less than 85 mm of Hg. like a maintained saturation, a patient is maintaining a saturation, and when that decreases, falls.
I'm not asking about the value. I'm asking about when the patient's pulse oximeter shows 85%.
Yes.
What will you think of? Patient is in
Hypoxemia, sir.
hypoxemia. It is an
Hypoxemia.
indirect evidence of hypoxemia, isn't it?
Hypoxemia. Yes, sir.
So it can be also called a hypoxemic state,
Yes, sir.
correct?
Yes.
So that is what the whole thing. Is hypoxemia a crisis situation or a normal situation?
It's a crisis situation.
Crisis situation. So when this question is asked, especially the causes of intraoperative desaturation and troubleshooting, the examiners expect you to add a word called crisis management,
Yes, sir.
for which there is a mnemonic called cover ABCD a swift check. So
Yes, sir.
that has to be mentioned. Except that you have done everything correctly, very nice presentation.
Yes.
So if you add this cover ABCD to check to this answer, it will become a wonderful complete answer. Okay. So I
Yes.
just show you a presentation.